Okay. Let's see here, just making sure everybody that this is working. Bear with me as usual as I try to get technology to cooperate with me. Let's see here. So it looks like, oh, there we are. So yay. So welcome everybody. Super excited for this topic tonight. Menopause is by far one of my very favorite topics to discuss, simply because it is such an underserved, underappreciated group of women who just have to suffer unnecessarily through that phase of life. It's like we have enough phases of life that we have to suffer through to begin with, that why do we have to do it again as we get closer towards the end? And what can you do about it? And so for anybody who doesn't know who I am, my name is Lindsay Venn. I'm a PA, I'm a registered dietitian, as well as one of the founding members of the Society of Metabolic Health Practitioners. And anybody please put in the chat, or if you're here on Zoom Live, feel free to use the chat, and I'm happy to answer questions as we move forward. So on my journey, I started out as a dietitian and I got into the medical world as a PA so I could do more. Helping people with their diet was very rewarding. It still is, but I wanted to be able to do more. And that's what led me down this path and why I have such a passion for menopause, as well as other things like metabolic health and diabetes and any other chronic disease. And so the goal is here just to do that for you, is we're going to educate and empower you to either speak to your doctor, work with your doctor, or seek out someone else if not able to do it. So I'm going to be admitting people kind of throughout this process, so don't mind the pinging that you'll hear. Welcome, Kathy. And I will share my screen and we will move on. Learn all about menopause. Let's see here. Share. One more share. And we should be popping up. Perfect. And for anybody who might just see the hour or whatever this plays, is saved on my YouTube channel. And so if you aren't able to join or aren't able to watch this while it's here on Facebook, you can certainly go to my YouTube channel at Venn Integrative Medicine, and the recordings will remain there. You can obviously share them with people from there as well. And please share away. I am trying to grow my business and appreciate any help with that. So first, today, day one, menopause and why it matters. Let's get into it. So I always like to remind people, what is menopause? Why does it matter? What is the problem that may have, or not the problem, but what physiologically leads to it? And a lot of people don't know this, but all of us women are born with all of the eggs that we will ever have. They're all created in utero. We do not make any more eggs as life goes on. Men are a little bit different. They continue to make sperm as life goes on, and that's why men can have children at 70 or 80 years old, where women really cannot. Our eggs, once we've ovulated all of our eggs, that's when menopause happens. So some other terms, menarche is the onset of periods. This is when we start our period. We have monthly ovulation to get rid of those eggs, or to hopefully fertilize those eggs every month until the eggs run out. And that is when menopause happens. It's when ovulation stops or becomes more intermittent because the number of eggs, we've gone through them over time. So what are disruptors in menstruation that we might have? So birth control is a very simple one. Birth control of any kind can disrupt menstruation. Different hormonal anomalies that are very rare can obviously happen as well. Things like PCOS, this is a big one. Again, the number one cause of infertility in women is PCOS, which is a hormonal anomaly of sorts that is very much tied with insulin resistance. Some women, if they suffer from eating disorders such as anorexia, or if they're severely underweight, some of our athletes, some of, gymnasts and things like that, have disruptions in their menstruation because their body fat percentage is too low, and they'll lose their period over that. And then we get into the menopause phase. Then we have perimenopause, where our periods become very irregular, and it might be irregularity in timing, it might be irregularity in flow, or in duration, or in even just the PMS symptoms. So you will have disruptors there. And then again, in other rare conditions, things like, a hymen that has the inability to be broken, things like that can lead to problems too. But again, those are very rare. So perimenopause. So this typically begins in our early 40s. The average onset of perimenopause is about the age of 44, and this can last a long time. 4 to 8 years is what they show in the research, can last as long as 10 years. And so this can be a really trying time because during that phase, our hormones are all over the place. Most women experience changes in their periods, and that's one of the first clues that they've got. But some other things that they might experience would be things like disruption in sleep, changes in mood. This is when we feel like we're going crazy. We start to gain that weight, particularly that spare tire around the midsection. And several women will start experiencing things like hot flashes or night sweats, maybe some vaginal dryness, or maybe just the symptom of, I used to run cold and now I run hot. It could be as simple as that. Again, this is that phase where we just think we're going absolutely crazy. And if if you've had a hysterectomy or something along those lines, still have ovaries intact and you just don't know, if you feel like you're going crazy, that might be part of it. So the progression on to menopause is defined as someone not having a period for more than 12 months. And so your doctor will label you with menopause once you have exceeded that 12-month timeline for no periods. A lot of times women will have, hold on 2 seconds, I'm getting a little feedback here. Sometimes women will have, and that's not what I wanted. They'll go 3 to 4 months without a period and then they'll have one, or they'll go 6 to 8 months and not have a period. That's when, it's the true definition is 12 months or more. This typically occurs full menopause between the ages of 45 and 55, and the average is between 50 and 52. This one, most people will experience some hot flashes and night sweats. The vaginal dryness or dyspareunia, which stands for painful intercourse, can become a real problem. The libido tanks, the brain fog worsens, and the weight gain is most certainly an issue. So some other symptoms though, and these ones I really wanted to point out because some people don't get hot flashes. They're lucky, they don't have to go through that whole process, but they'll experience other things. So things like really crepey skin can happen, joint pain, depression and anxiety, migraine headaches, maybe that have either gotten worse or have just started. Low stress tolerance. I like this one because this one kind of speaks to most of my perimenopausal or menopausal women is they can't tolerate much. They get frustrated or irritated much more quickly than they would have. They don't handle stress from their job as well. And so that's a big one. Insomnia is huge. Insomnia is very common in menopause and obviously a problem for a lot of reasons. Decreased flexibility in our joints. That's a big one. We do notice more joint pain again, but decreased flexibility. More frequent UTIs, which can also lead to incontinence. Things like brittle nails and hair loss, reflux, dry eyes, increase in blood pressure, which is the tie to insulin resistance we'll dive into deep tomorrow. Even things like dizziness, vertigo, numbness and tingling, and heart palpitations, all common symptoms that can occur in menopause. But this is where it gets worse. Those are symptoms. These are big problems. The big problems that occur with menopause, osteoporosis, big one, very big one. They show that women have an increase in things like osteoporosis by over 50% because of the lack of hormones. Cognitive decline and dementia, this inappropriately or over resoundingly affects women more than men once we go through menopause again. Heart disease becomes the #1 killer in women after menopause. Sarcopenia, which is muscle wasting, is a very big problem too. This is the #1 thing that will put a woman in a nursing home. And so we have to be very careful with maintaining our muscle mass. Cancer. Now, this is the one where we really are going to get into it when we start talking about hormone replacement therapy on Wednesday. We were all told for a very long time that you can't take hormone replacement therapy because it will cause breast cancer. That dogma has been erased. This is no longer a concern. The jury is out. There is no increased risk of breast cancer or other female cancers in hormone replacement therapy that's done right. So, and then also pelvic floor dysfunction can be a real big problem. That can include, again, the urinary incontinence, prolapse of different areas can be a problem for sure. The other piece I want to bring back to the breast cancer bit there is you notice most women don't get breast cancer earlier in age. Maybe there's a part of this where the hormones are actually protective. It tends to be later in age, not always, but tends to be later in age that we get things like breast cancer. So why do these things happen? Female hormones are systemic regulators with protective signaling in every tissue of the body. They're protective, and that's really important to get there. They're not just a hormone that, has us ovulating every month. They actually have protective signaling in, like I say here, nearly every tissue of the body. It is the master regulator. Estrogen itself is. We'll talk about the other hormones as well, but estrogen is the master regulator, and it can impact greatly things like metabolic, vascular, and neuro, our brain again, our cognition, our brain fog, those kinds of things. So they're very protective, or estrogen is very protective when it comes to these things. So what does estrogen actually regulate? So estrogen itself is really important in mitochondrial function and energy production. And that's why we get more tired. That's why we don't sleep as well. That's why we don't perform as well in the gym and with our jobs, is our mitochondria is not being as regulated as it would have been before. And so very important for mitochondrial health. Things like glucose and lipid metabolism are very important. And again, tomorrow we'll really dive deep into that. Inflammation and immune balance, another thing that estrogen very strongly regulates. Vascular tone and our nitric oxide production is also there, and that's why blood pressure became more of a problem. Say, I hear somebody, and sorry, whoever's in the Zoom, if you wouldn't mind mute yourself. I can't see that screen for some reason. Neurotransmitters, and again, synaptic plasticity, so the ability to have our brain firing like we want it to fire. Collagen synthesis, that's where the crepey skin comes from, and of course, bone remodeling and the osteoporosis connection. So estrogen's super important, and certainly not to be balked at when it comes to someone who may or may not want to do HRT. Progesterone. So progesterone is they call it the stabilizer when you look it up. I call it the calming hormone. It is the thing that just kind of helps to calm everything down. I love it. Most of my women love it. Very important hormone that also diminishes in menopause. And so it does modulate GABA, which impacts calmness and sleep. It is important to help balance it out with estrogen. This term estrogen dominance has been there, and you hear it all the time. What does that mean? If someone goes on estrogen and doesn't also go on progesterone, they're going to get some estrogen dominance because of that lack of balance. And so progesterone is really helpful there. It also will support our bone health. It'll also help improve insulin resistance. It will also help improve the neuroprotection. And it can, and I see it all the time in patients that we measure the labs on, it can decline years before our estrogen actually does. And so a thing that's really important to make sure to have on the radar when it comes to hormones. So, and sorry again, whoever is in my Zoom, please feel free to chat in the message. I just can't see that screen. I'm learning, I'm learning the technology as we go. So testosterone, the last hormone, and this one I also don't want people to balk at. Testosterone is what I call the feel-good hormone. When you look it up, they call it the protective hormone, particularly protective when it comes to muscle mass and strength. And so testosterone is a wonderful thing to make sure we have optimized to the best of our ability when it comes to our lean body mass. It too will support bone health for my ladies who can't take estrogen because of things like breast cancer history. I always put them on testosterone to support and save and protect their bones. Great for improving things like libido and motivation and drive. I had a gal this morning who said to me, wow, for the first time in months, I actually want to get up and get going, want to get to my list. It can really be impactful there. I love adding testosterone to my people who are trying to improve their diet and lifestyle, because that motivation and drive to do those things with diet and exercise is much better. Cognitive resilience, brain fog improvement is probably one of the number one things I hear in my ladies who are on testosterone. Their brain fog gets much better. And two, it will help with insulin resistance. So, and I love this little quote, I pulled it out here. It says, it really is, menopause is a transition from hormonal resilience to hormonal deficiency, and it is a big problem. So what about insulin resistance here? And I'm going to list a lot of the things that we're going to talk about, but we'll dive deep into insulin resistance tomorrow. women in menopause have an increased risk of insulin resistance, period. And the statistics, I believe I'm sharing with you tomorrow, but it definitely happens. That's why we go from having our weight, where we carry our weight in our butt and our hips primarily, and that's what this image was for. We start out there and then we progress to look more like a man. We start to carry the belly fat and the protruding beer belly and things like that. Lack of estrogen, this is why men carry their weight in the middle, is because they have a lack of estrogen. Well, we transition to that, and that's why we start to have more of that body phenotype of a man with that central adiposity once we hit menopause. Women with type 2 diabetes tends to have further progression when they have menopause as well. Again, I talked about the visceral fat. Fatty liver becomes far more prevalent in menopause. And again, of course, because it promotes insulin resistance. Heart disease. This is a big one. Again, it's the #1 killer of women who are menopausal age or older. We don't have heart attacks early in life. You don't hear of women having heart attacks in their 20s or 30s, even early 40s. And that's because of the cardioprotective benefit of estrogen. Insulin resistance will lead to higher blood pressure. And so blood pressure is a component of heart disease. And so if we have insulin resistance from menopause driving that, plus we have the decreased nitric oxide production, that too will lead to higher blood pressure, as well as that inability to vasodilate as well. We do see increases in inflammation as well. A lot of times that's those symptoms of joint pain and decreased flexibility. And again, it is unfortunately the #1 cause of death. So something to really pay attention to if you want to prevent this. Osteoporosis. I think this is probably the #1 reason why women seek me out when it comes to looking for other options for helping their bones. And so we do see this acceleration in bone loss that happens once we hit menopause. We don't see osteoporosis in our 20s, 30s, 40s, unless there's something else going on. So the hormones absolutely matter. The really bad downside here is the guidelines for checking for osteoporosis, and we do that by way of a DEXA scan. The guidelines don't recommend to start until you're 65. Well, if you're started menopause at 50 and you don't check your bones until you're 65, that's a big problem. And so I do recommend to start checking DEXA scans when you start menopause in order to keep close eyes on that. And there are a lot of really cheap, I think you can get a DEXA scan cash pay for $75. So if your doctor won't order it or your insurance won't cover it, getting a DEXA scan if you're peri or postmenopause, really, really, really important. So the other piece I put in here too, it's funny, men's guidelines to check for osteoporosis don't start till age 70. And just as a reflection of why estrogen matters. Men just don't need them as early because they don't have that lack of hormone. They'll have their testosterone protecting their bones, where women have this significant decline. Sarcopenia, this is another really big one, and we talk about this a ton at Insulin IQ, but of course we'll talk about it here too. It stands for a loss of lean mass. And so women, the reason that they get put into the nursing home isn't necessarily because of the reduced lean mass, but it's because their strength goes away. They fall, they break a hip, or they have some other kind of fracture that's also related to the osteoporosis. And so this is a really big one and should be a focus of anybody menopausally aged. You will see a reduced metabolic rate related to this sarcopenia as well. As we lose muscle mass, metabolic rate can decrease. And again, big reason, #1 cause of nursing home admission. So it's really important. Brain health is huge too. And the Alzheimer's impact is huge. I want to say it's something like 6 to 7 times more women than men who are menopausal, of course, get Alzheimer's disease compared to men. And so it's that lack of estrogen, that lack of hormone that leads to more of this. It is very neuroprotective. Our synapses will start to fire more slowly simply because we have less estrogen. And then again, the insulin resistance piece. If anybody who's heard me speak before about insulin resistance, our brain can become very insulin resistant, just like any other tissue in the body. And if we can't use the glucose that we get from a standard American diet, we're not making ketones as the second alternative fuel for the brain, we have big problems that further worsen not only the hormonal aspect of brain health, but also the insulin and fuel source when it comes to brain health. Sleep and stress, this one's a big one too. For anybody, again, who's heard me speak, Number one, there's three causes of insulin resistance. Number one, your diet. Number two, stress, which I include sleep in there. And number three, inflammation that we talked about last week. Insomnia is probably the most complained about and verbalized symptom that women come to me with. And it's the hormones. Either you're having hot flashes, you don't feel well, or you just can't sleep. Definitely related to menopause and the lack of hormone. There is an increase in dysregulation of cortisol. And so I do test women all the time with a 4-point saliva cortisol test, which will show that they've got really low cortisol in the morning, which that doesn't provide you with the energy you need to get up and get going. And then they'll have really high cortisol in the middle of the night, which further prevents that sleep. And so really plays a major role here. And then the mood disorders are extremely common. You'll hear women talk about this all the time, that, they had this purpose in life of this desire to take care of others and to, be motivated and get things done and all these things. And when menopause sets in, we're not that person anymore. And because our moods have changed, we're feeling a different role. And so this is just really a sad and strong side effect of menopause. Gut health and inflammation. This actually, again, plays a role. The inflammatory piece, of course, with the insulin resistance, but we do see changes in the microbiome because of estrogen's role in the microbiome. And so this can be a problem with things like leaky gut, altered digestion, alterations in constipation versus diarrhea. We have a reduced ability to actually cycle out our estrogen if we are taking estrogen, so that can be a problem. And then again, like I mentioned, the changes in our symptoms. Bloating's a big one I hear complaints about all the time too. Again, lack of estrogen. This one's a big one too. I actually have a patient that I met with this morning who, she's a breast cancer survivor, and her quality of life is so negatively impacted by her lack of estrogen. She's been doing everything and trying everything she can to impact this. She's kind of in a tight situation because of the breast cancer history, but everything suffers. Relationships will suffer. One, because of the mood changes. Two, because you don't, your libido's gone. You don't care if you ever touch your spouse again. Three, because of the pain that can come with intercourse or the lack of lubrication that can occur. So intimacy is often forced, which is not, none of us want to be in that situation where we have to force intimacy, and our spouses definitely don't want to feel like we're forcing intimacy. So that's a big problem. Again, the self-identity piece and our purpose and the resulting, anxiety and depression that can occur. And so this is a big one as well. So I do say here, estrogen and hormones matter. And if I can't, hopefully I sold that. That's my job, and my purpose here was to sell to you or to convince you that these hormones really, really do matter. And if you're in a place where you can do something about it, it's really important to do something about it. Again, it is the number one, in my opinion, underserved population and the underserved stage of life that we go through. And this isn't because nobody wants to help. It's because doctors are not taught how to help. I did not learn about menopause and how to treat menopause in medical school. It wasn't even brought up. We all learned the cycles of life, but that's all we learned is that, oh, at this point in life, they go into menopause and this is what they can expect. But we're not taught how to help. And that's where myself and others like me really like to make a big difference. The dogma of the Women's Health Initiative was so powerful. I mean, back in 2002, when that Women's Health Initiative research came out that said, oh, hey, if you take HRT, you got to get off of it now or you're going to die of breast cancer. That stuck for a very, very long time, 20 plus years. Thankfully, this has all been reversed. You will hear, and I talk about it all the time, or my patients will come to me and say, I went to my doctor and they said, this is just something you better get used to. This is a natural phase in life that every woman goes through. And so suck it up, buttercup. This is just the way it is. Not the case. I don't ever want to ever have to say those words to a patient. And I just want people to be aware there's so many options, and we'll talk about them. There is hope. That's the number one piece here. There is hope for menopausal women in improving their quality of life, their risk of chronic disease, their weight, all of the things that we complain about in menopause. So, and here's just that post that, yeah, finally the FDA did correct their statement or their black box warning on hormone replacement therapy. It is no longer a concern. Hallelujah. So, what do I recommend from here? Number one, learn more about hormone replacement therapy for sure. And we're going to dive deep into this on Wednesday. And so, if you want to learn from me, please join on Wednesday. If you want to learn outside of this, there's two really good books that I recommend. Dr. Marty McCary, who's now our FDA leader, who got this black box warning pulled off, he has a book called Blind Spots. And then there's another one out there called Estrogen Matters that I really, really recommend if you want to learn a little more on your own. Work on finding a well-versed and willing provider. You know, if your provider is being forced into giving you HRT, they're not going to have the experience and they're not going to have the desire to optimize what it is you're doing. So do your research, look for a functional or an integrative provider who does hormone replacement therapy. Worst case, not worst case, maybe best case scenario, you can always come and see me. And lastly, this one is huge. You have to advocate for yourself. If you know that you could be on hormones and you know you could feel better and you know you could improve your health span, not just your lifespan, but your health span, and someone isn't going to support you in that, find somebody else. You have to advocate for yourself here because this is so unbelievably important. And again, like I said, you do have a one-stop solution. If you want to come see me, I'm always happy and willing to see women, even if I can't necessarily prescribe your HRT. We can walk through everything, your lab results, your symptoms, your different options. You can be educated completely on the different options, and then you can move forward with your provider from there if you need. I think that's, oh, nope. Thought that was the end. It's not. So tomorrow, what are we going to talk about tomorrow? The science between menopause and insulin resistance. And it is very interesting and they're very closely tied. And we're going to compare it a little bit to PCOS. And so you can understand the physiology behind it. Why do we gain weight in menopause? Why is this a thing? Number three, lifestyle strategies that you can do to help. There's always something you can do to improve the insulin resistance, even in the face of menopause. And then we'll discuss some different supplements that you can do that are not full-on hormone replacement, but some supplements that can make a big difference. And then Wednesday, we're going to talk about who should and who shouldn't do HRT and why, the pros and cons that you might have from the different forms of HRT and the different hormones that are included in HRT, the different routes of administration that you can consider and why we might choose one over the other, which testing you have to have done, and then what that long-term picture looks like, because I hear it all the time. Oh, when should I stop my hormones? Well, probably never, but we'll discuss that again on Wednesday. So again, if you want to reach out to me, you can find me Ven Integrative Medicine. I have a website, I've got my Facebook page, I've got my YouTube page. So please reach out. I'm always happy to help. So, Kathy, thank you for being in the Zoom. You're the only one here. And if you would like to ask a question or something in person, we can certainly do that. But let's see here. She says, can women over 60 still take hormone replacement therapy? It's a really good question. And the answer is it depends. So there is an arbitrary, and we'll talk a lot about it on Wednesday, but there's an arbitrary line in the sand of if you're 10 years more out of menopause or 10 years or more since your last period, you have to be cautious. Doesn't mean you can't do it, but you have to be cautious. If you started menopause at 55 and you're 60, absolutely. We start it sooner rather than later because you don't want to get into that 10-year window where there's that need for caution. If you started, I had a lady the other day who started menopause early 40s and she was like 55. So she had crossed that 10-year mark. But that's when I look at the entire picture. If this is a vibrant, healthy, active, great diet, everything else looks really good. We discuss the options. And in someone like that, I would recommend to do it. You just have to do it correctly so that, you're not creating any additional risk when it comes to starting HRT more than 10 years out. So, and for any woman, it doesn't matter how old you are or how long you've been menopausal, vaginal estrogen is always a really good option. At worst case scenario, if that's all you can do, you can, support that vaginal tissue. You can prevent things like urinary incontinence and UTIs. You can keep that pelvic floor integrity in place. There will be a tiny bit of systemic effect, but nothing good enough to support bone health or cardiovascular health. But if anything, at least, I said it to one of my doctors that I worked for. I said, you know, we can make ourselves as healthy as we want, but if you never want to have sex with your spouse again because it hurts so much, what's the point, And so there are definitely things that you can do. So great question. Let me pull up my phone for the anything that might be in the chat there. Sorry, I gotta mute it though too. For the So let's see. Rosa, hi, darling. Ellen asks, if you decide to do HRT after you cross the 10-year mark, what does it look like to be cautious? Are there tests that can determine if you're entering a danger zone? So great question. And so oftentimes I will measure what's called an FSH. And again, we'll talk about this in a lot of detail Wednesday, but FSH stands for follicle stimulating hormone. It's the hormone that comes from our pituitary gland that screams at our ovaries saying, I want you to make more estrogen. I don't have enough estrogen, please make more. And so when you first start into perimenopause, that FSH is going to be all over the place. One day you're making hormones, the next day you're not. So FSH, if we catch it high, greater than 21, then we can say, yep, you're definitely in perimenopause. If we catch it low, we don't know, in perimenopause. In menopause, that number will go up gradually over 4, 5, 6 years. It'll reach up into the hundreds even. And then after a period of time, that pituitary gland gives up and it will say, okay, I give up. My ovaries are dead. It's going to start to come down and decline. So for me, when I'm looking at somebody who wants to start after that 10-year mark, if their FSH is still really high, their body still wants it, and the likelihood of there being a problem is a lot less. If their FSH is in the 30s or 40s, when they're more than 10 years out, then there's definitely more of a concern. And in that situation, I typically recommend to do testosterone only because you can still have the bone and cardio protection and neurocognitive protection and whatnot in a safe way. So I hope that answers your question, Ellen, there. So looks like we have a couple other people. Karen says, finally something that makes sense. Yes, I try really hard because like I said, I'm menopausal. I started menopause at 44, I think. I had a partial hysterectomy, but that's when the hot flashes hit. I'm about to turn 50 and without HRT, I would be a train wreck. And like I said, I'm super passionate about this and there are so many women out here who need more of this. Oh, Cindy says, thanks for doing these lives. Super informative. You're very welcome. Again, I have two purposes in doing these lives. Number one, I am trying to get the word out. If you don't know there's options, if you don't know how to educate yourself and turn around and advocate for yourself, I want to be somebody who can help you with that. Number two, I am trying to grow my business. And so any additional support, share away, please. I'm trying to grow this business so I can quit a job that I don't necessarily want to remain in. And so share away. I'm happy to have that happen. The busier I can get, the better I will be. So awesome. Well, that looks like that's about it, unless anyone else has a comment or question. Again, tomorrow it's going to be at the same time, same place. We'll talk about insulin resistance in a lot of detail and how it relates to menopause and how you combat it during menopause. And then the last night is a big old deep dive on HRT and all the things that you need to know when it comes to that. So awesome. Well, everybody have a great night. It's been a pleasure. Oh, I got one more. Tanya, what are your thoughts on bioidentical versus synthetic? We'll talk about this on Wednesday also. I strongly like the bioidentical form. I've always recommended bioidentical over synthetic. For people who don't know, bioidentical means it's exactly identical to the hormone that we would have in the body. And why wouldn't we want to do that if we could help it? Synthetic hormones are not. There's a change in the structure of those hormones, and so they can be what we call endocrine disruptors, meaning they'll bind to the receptor site of the different, like I said, every tissue in the body requires this. If a altered structure binds to that receptor site and can't be utilized, you won't get the same benefit, and it can actually disrupt any benefits that you get from other, estrogen that you might have on board. And so, yes, definitely in my opinion, that gal that wrote the book, The Estrogen Matters, doesn't feel that way at all. She doesn't trust the compounding pharmacies. I've worked with dozens and dozens of compounding pharmacies, and I have never had a problem when it comes to the quality of the product, the consistency of the product, how they regulate it, ship it, all of that kind of stuff. And so I really do prefer the bioidentical form, but I'm not scared to use the synthetic if money's an issue and we have to go through an insurance. So yay. So awesome. Tanya, you say you will be here on Wednesday. You will learn a lot, I promise. So awesome. Well, thanks again, everybody. I really appreciate your support in this journey that I'm on, and I'm hopeful that this has been really educational and helpful. So thanks, everybody.